Good evening, everybody. We'll just give it a moment as everyone files in. Good evening, Dr. Dunbar. How are you tonight?
Great, thank you.
I
Doing
almost
well.
said happy Monday, but it is Tuesday.
God,
That
thank God it's Tuesday.
I know. I'm sure everyone on here felt the same way all day. I thought it was Monday. So here we are, but without further ado, let's get started because it is a Tuesday. So we want to make sure we get everything in on time. So welcome to tonight's Wu University event, the Glaucoma Puzzle, When the Pieces Don't Always Fit with Dr. Mark Dunbar.
Thank you.
You're welcome.
Here we go.
I'm your host, Dr. Jennifer Stewart, and thank you to AbbVie for exhibiting at tonight's event. So just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and throughout the presentation, please use the Zoom on-screen floating panels, chat, and Q&A to ask questions. We'll leave time at the end for a great Q&A.
Oops, sorry.
That's okay. If you're on a mobile device, you can find Q&A at the top and find chat under more. It's my great pleasure to introduce Dr. Mark Dunbar. He's been a member of the optometric staff at the University of Miami's Bascom Palmer Eye Institute for over 35 years and currently serves as the Director of Optometric Services. He's a fellow of the American Academy of Optometry and is a founding member of both the Optometric Glaucoma Society and the Optometric Retina Society. Dr. Dunbar serves on the editorial boards for Review of Optometry, where he wrote the monthly column, The Retina Quiz, for over 20 years. In 2021 and 2022, he was named as one of the top 150 optometrists in the nation by Newsweek magazine's annual survey. Welcome, Dr. Dunbar. We're happy to have you. I'm going to turn it over to you, and I'll see you at the end for the Q&A.
Well, thank you very much. Appreciate you guys asking me to be a part of this. It's always a lot of fun. 50 minutes flies by pretty quick. And then when I look at the number of people that are signed up and on this, it's staggering. So thank you all. Here are my disclosures. The full disclosure, really nothing I say in this lecture will have been an original thought. I have shamelessly copied and pillaged almost every thought or concept discussed. So I'm not smart enough to think about many of these things, but obviously, when we think about glaucoma and why does it matter, I think this is something that as primary care or medical optometrists, this is something we see every single day in our practices. And of course, I think the challenge that we ask ourselves over and over when a patient comes in and we measure a pressure and we look at an optic nerve, does this patient have glaucoma? And we know it's not always as easy as it seems, which is really the genesis of this talk, right? Why does glaucoma matter? Well, partly because it's the second leading cause of blindness in developing countries. 40% of patients, when they are diagnosed, already have moderate to severe visual field loss. And we know that even when patients are treated or adequately treated, about 10% of them can continue to progress. And so obviously we want to diagnose it as early as we can before patients have moderate to severe visual field loss. But the other, I think, sobering statistic is over half of all glaucoma patients are undiagnosed. And this was borne out in most all of the population-based surveys that have been done, including the Baltimore Eye Survey, the Parecto VER study, where, again, over 50% of patients who were diagnosed with glaucoma in these population-based studies, didn't carry that diagnosis. So again, we know that's sometimes because patients don't come in to get their eyes tested. And if 100% of them did, maybe that number wouldn't be as high. But the fact is, right, not everybody is cookie cutter, not everybody is textbook, and not everybody that we look at, sometimes we miss it. It may be early, and there may be a number of factors that go in. And so we're going to talk really about a number of cases just that I think really are not really kind of cookie cutter, where the pieces don't always fit. And of course, as we already alluded to, many suffer visual field loss before the time of diagnosis. And so you think about it, right? We've got an aging population, and the statistic on the left here, I think, is sobering, right? 10,000 people a day turn 65 in this country every single day. And for me as an optometrist, to me, that is, I hate to say it, that's exciting, right? If you're practicing medical optometry, medical eye care, we know as we get older, there are more patients with disease. So certainly more patients with glaucoma, more glaucoma suspect. There's more dry eye and ocular surface disease. There's more cataracts. There's more macular degeneration. There's more diabetes and diabetic retinopathy. And again, these are all conditions that as primary care optometrists, we see, diagnose, and certainly manage in our offices. So I look at that as really an opportunity for us. So if I were starting out, again, I would be very excited, because if you've got an OCT, you've got a wide field camera, there's a lot of stuff, of course, in visual field, there's a lot of stuff you can do and not have to send these patients out. And so not only is this population aging, but you look at specifically these higher risk patients who we worry most about in glaucoma, the African-American population, the Hispanic population. That number is said to increase as well significantly. As you see the bullets here, 70% by 2012, which of course we're already past that, to 34% by the year 2050. And so what's optometry's role in glaucoma? And I would answer, well, why not optometry, right? We are the gatekeeper of eye disease in this country. Most patients get to a subspecialty ophthalmologist by way of optometry often. So whether it's a retina problem, whether it's a glaucoma problem, whether it's a cataract, we are really on the front lines of this disease. And the fact is, access to subspecialty care is really very limited. Try to send the patients for cataract surgery or to a glaucoma specialist, and as you'll know, the waiting time to get an appointment is sometimes several months. And so, yes, we've got all the technology needed to diagnose and manage these diseases. I think the demand exceeds the supply for subspecialty eye care, and the fact is, we can do it just as good as an ophthalmologist or even better. And again, in the era of technology, I would say the difference in quality between subspecialty care is not necessarily better. I think it's, again, because of technology, I think the playing field is leveled between optometry and ophthalmology and just about every subspecialty that doesn't involve surgery, of course. And so if you want a definition, of course, primary open-angle glaucoma is a chronic progressive optic neuropathy in adults. Probably doesn't have to be in adults. I guess if it was younger, maybe we wouldn't be calling it primary open-angle glaucoma, but characterized by acquired atrophy of the optic nerve and loss of the retinal ganglion cells and their axons. Note that this definition does not say anything about pressure. And again, I think we all know what that definition is. So in terms of the puzzle, right, I think one of the most interesting things that we do, as I've kind of alluded to, is, right, the patient who comes in the door, is this glaucoma? And of course, do they have any other pathology? But really speaking of glaucoma, looking at a nerve, does it look glaucomatous? Does it look suspicious? Measuring a pressure, is it elevated? And as we said from the beginning, it's not always as straightforward as it seems. And again, we'll look at a number of cases. We won't have time to really delve into why patients develop glaucoma, whether it's genetics or other factors. That is probably for another time that we can talk about. But yes, how we measure it, right? How do we diagnose? We measure IOP. We ask ourselves, is it normal? We know what the traditional normal is, anywhere between 10 and 21, but we know that patients can have a pressure of 15 and sometimes have pretty moderate or severe glaucoma, just like some people have elevated IOP, 25, 26, even 30, and don't have glaucoma. So we know that pressure probably is a key driver, but really for any given individual, we kind of wonder what role pressure really plays. Point being, obviously, if it's elevated, a red flag goes up. We look at an optic nerve, as I've said already. Does it look suspicious? Is it normal? Is there cupping? Is there asymmetry between the two eyes? We look at features that might suggest that this patient has glaucoma. And other things, right? Do they have disc hemorrhages? Is there notching? Is there focal thinning? Obviously, family history. All those things, kind of go into this idea. Does this patient have glaucoma? Is this patient a glaucoma suspect? And does this patient need really a, quote, glaucoma workup? And so again, I talked about it earlier, every single day, right? When we look at a nerve, does it look suspicious? Does this patient have glaucoma? And, you look on the left, all these patients have pressure of 18. Very quickly, we can say, this nerve looks normal. It's round. It's symmetric between the two eyes. given a normal pressure, we can very quickly decide that this patient does not. You look on the far right, and by the same token, even though they've got a pressure of 18, I think you can see in both eyes that they've got an inferior temporal nerve fiber layer defect. Obviously, they've got a large cup and there's thinning. And so, again, whether the pressure is 25 or 18, I think we look at the right and say, yep, no doubt about that. This patient has glaucoma, and we proceed accordingly with a workup. The more difficult ones, the ones that we kind of scratch our head about, right? This is a patient here where, again, you look at the cup in the right, it's definitely bigger than the cup on the left. And then we start looking a little more critically, right? Is there thinning? Is there notching? And what you will see that the cup on both sides is round, but again, the nerve in the right, the cup on the right is a little bit bigger. And again, patient, do they have glaucoma? Certainly warrants a glaucoma workup, meaning visual field, OCT, etc. Now, if you were looking more carefully, you might notice that the nerve on the right is bigger than the nerve on the left, and we know that big nerves can have bigger cups. Before the era of OCT, when we would look from one eye to the other eye, that was a little more difficult to notice. Again, looking at a photograph, you can see that a little bit easy. Fortunately, OCT, I think, helps us make that decision a little bit more quickly. But again, I think we'd all recognize that patient's a glaucoma suspect. We would get an OCT, we'd probably bring them back, measure the pressure again, and do a visual field. And again, this is a patient who didn't have a pressure of 18. Her pressures were anywhere between 20 to 24. So they were just high enough to arouse suspicion. And then when you looked really at the cup to the optic nerve asymmetry in terms of size, no question, this patient is a glaucoma suspect. Unfortunately, at least during the time that we saw them, they didn't go on to develop glaucoma. OCTs and everything were completely normal. But you look at this one, right? This is a patient who I had inherited after having had cataract surgery. And who knows if they were highly myopic? I don't remember. But again, I think you look at this right eye, you see that the shape of the nerve is a little bit abnormal. And if you look more carefully, you also see that inferior temporally, it looks like there's thinning and notch. So as again, they've never had elevated pressure, but again, you look at this asymmetry, not only in the appearance of the nerve, but obviously the appearance of the cup as well. And so the question is, all right, does this patient have glaucoma? Do we need to do a workup? And I think we'd all agree that we do. And so you look at the OCT, this is August 2021. And the OCT really almost mimics what we saw in the optic nerve. You see on this deviation map that there's this inferior temporal nerve fiber layer thinning. We see on the clock hours and the quadrants, it's consistent with what we saw on the optic nerve. The left one really looks pretty good, small cup. There's this little deviation map up here. Overall, and let me see if I can get a laser pointer here. There we go. We'll do laser pointer. Good. Right? I mean, you can kind of see that the nerve fiber layer is a little bit thicker here than it is here. So, no question, this looks suspicious. And again, maybe the pieces of the puzzle don't always fit. Does this patient have glaucoma? Interesting that we're going to fast forward. That was 2021. We're going to move on to 2023. And I think this is around the time that I saw him when I was looking back and comparing imaging. The question is, obviously, they got an abnormal OCT. Has it changed or gotten worse? And again, is this just an anomalous optic nerve? Maybe they were born that way. This isn't acquired. Again, these are, I think, the questions we ask yourself. Notice that, we're looking at really pretty poor signal strength. So it's not the best scan that you would like to have. I like at least a 6, but obviously a 7 or higher, I think, is even better. And again, you look at the ganglion cell complex, and even though overall there's thinning, you really don't see a defect that is consistent with maybe what you see with glaucoma. And so when we compare that 2021 visit to 2023 visit, and again, just looking at the thickness maps and the deviation maps, really it looks almost identical. And then I guess if we look even a little more closely at those clock hours and deviation maps, I like looking at the numbers, right? And the question that I would ask you that you should think about when you're looking at these OCTs, how much change needs to occur for it to be significant? So if you're looking at these little clock hours, how much change would you need to see for a red flag or for you to say, uh-oh, this looks like this patient has gotten worse? So remember, glaucoma is not only a disease about, do they have it, but remember, it's a disease about progression as well. So, we don't know well, we'll look at pressures in a little bit, but we don't know at some point, did they have elevated pressure? Is this just a congenitally abnormal nerve? The point being, anyway, from 21 to 23, when you look at these numbers, really, they're almost identical. And the number that you really want to see to answer the question, a change of more than 10 microns really is significant. Doesn't necessarily mean that you would pull the trigger, but if you saw 56 and now they're 46, then you would, I think, at least be suspicious enough to wonder, is there a change? And I would say, at least from this 2-year interval, really the OCTs has not changed. And of course, if luck would have it, as is these cases where the pieces of the puzzle don't always fit, this isn't the best visual field test taker. That 23 visit that we looked at here, you can see that there's some kind of generalized depression. And then when we look, this is from May to 23, January to 24, again, I don't think you can really rely too much on the OCT. And by the way, you look at the pressures going back to 2015 and even before that. Remember, I said the pressures have always been good. I think you can see here the pressures have always been good. And so definitely a glaucoma suspect, certainly a suspicious nerve, but are you suspicious enough to pull the trigger and say, this patient needs to be on treatment? And you can see this was my note from when I saw them. Yep, he's a suspect based on that thinning, tilted disc, visual field nonspecific. Ultimately, I chose to just watch this patient over time, bring him back in 6 months. We'll do a visual field again. We'll check him with applanation tonometry, etc. So, the thing about, again, some of these glaucoma cases where the pieces don't always fit, sometimes it takes a while to really come up with really I hate to say an answer, because you're always scratching your head. Is it glaucoma? Do we need to start treating? And again, they can always be a glaucoma suspect, but at some point with enough information, you may make a decision one way or the other. And so does he have glaucoma? Does he need to be treated? As I said, I don't think so, but we continue to watch him at least twice a year. We know that when we look at the nerve that it's variable, right? From patient to patient, from even racial groups. We know that the African-American population tend to have bigger cups and bigger nerves. Again, this is work from Jost Jonas. The average cup to disc ratio is anywhere between 0.3 to 0.4. So that, again, individual variability makes it sometimes difficult to decide, is this just a normal nerve? Is it a glaucomatous nerve that we need to worry about? And again, where did they start within this journey, right? So we look at the ones on the top, all of them have pretty small cups. You kind of look down on the bottom here, and again, these are moderately large cup to disc ratios, but again, have they always been that way? And sometimes you don't have the benefit of really knowing where they started from. And so again, as I kind of describe to my patients when we talk about looking at an optic nerve and why this optic nerve may be suspicious versus another one, again, it's that individual variability. I always use just like some people have big feet and some people have little feet, some people have big nerves. And I always kind of use the donut analogy as well. It's like looking at a donut hole, trying to decide how big that donut hole is in relationship to the nerve. And I think patients understand that. And so again, I think we're very familiar with what is that physiologic nerve versus the glaucomatous optic nerve. Even a large cup, if it tends to be more horizontally shaped, it, I think, makes you feel a little bit better that this is just physiologic, whereas that vertically oval, non-uniform rim, obviously notching, some of these things we talked about are really more pathognomonic for glaucoma. And again, here's a great example of that, right? Obviously, vertical thinning and notching, you see nerve fiber layer defect. And again, we would look at that and instantly recognize this patient is a glaucoma suspect and probably has glaucoma, even though we don't even know what the pressure is. We know that this patient, whatever it is, it's probably too high. And again, a couple more examples, all right? That focal notching or thinning, both superior and inferior. And the patient on the bottom, right? Pressure of 16, 17, but yet you see they've got a disc hemorrhage and a red flag goes up. And we know anytime you see a disc hemorrhage, that there is a barometer that this patient could have glaucoma and probably necessitates a workup, as we've talked about, visual field and OCTs. And so we've kind of talked about looking at the size of the nerve. And again, OCT, I think, kind of helps us make that decision in terms of what is the average size. Is it bigger than normal? And again, comparison between one eye and the other eye. And we looked at this patient already where the right one is certainly bigger than the left one. And so, as we said, if we're suspicious enough, we'll do an OCT, we'll do a visual field. And again, ideally, you would also do a fundus photograph. I will say we've kind of done less fundus photos only because of the economics, right? Anytime you do an OCT, you would like to get the picture done. The problem is you can't get both paid for. And so sometimes we get a little bit of a lag time between when we do a fundus photograph and when we do our OCT in visual fields. And so again, I've been around long enough before we had OCTs and before we had digital imaging. You know, all our disc photos were 35 millimeter slides. We would put them in a stereo viewer and you'd look at these nerves stereoscopically. Again, not so much to make a diagnosis, but to follow these patients over time, right? Does it look like this nerve is changing? And again, retrospectively looking back, how difficult was that to look at these nerves and deciding, you know, unless it was really obvious, even among glaucoma specialists, it was very, very difficult. Obviously, the digital era, we still kind of did that, but I think nowadays we're looking at really a two-dimensional photograph and just really getting that, I don't want to say a rough estimate, but you know, getting an idea of what does that baseline optic nerve look like and does it look like it's changing over time. And obviously, we're in the era of automated visual fields, and we know that that's changed over the last, you know, 10 or 20 years with these visual field machines getting better. So yeah, sounds simple, right? 1 + 1 = 2. And as we know, it's not always as simple as that. And let's kind of look at a case here, and I call it, how do we handle a problem like Maria? And if you want to hum that to the sound of music, how do you handle a problem like Maria? Certainly you can. So this is a 57-year-old Haitian female that I took care of for many, many years. Initially, when I saw her in 2009, she comes in really just for refractive needs. We'll show her nerves in a second, but there's no question she's a glaucoma suspect. Interestingly, father was blind from glaucoma. So certainly that's something that becomes very worrisome, very suspicious. So good vision, pressure's 19/16, and she's got an average thickness, corneal thickness, maybe a little bit on the thin side, but you know, essentially average. And so you look at these nerves, right? With a quote normal pressure, I think we're all immediately suspicious. Could she have glaucoma? Is this glaucoma, especially in the setting of a family history? You look at the nerve on the left, the one that's got the bigger cup. It's a huge cup, right? Both of them are pretty large. And again, I think there's no question this patient is pretty suspicious. And so we do a visual field, and I would probably say that we would all say those are pretty normal. The right one that was less suspicious looks certainly normal. The left one also looks pretty good. And when you want to compare it really side by side, certainly if we thought this was glaucoma, that visual field doesn't really fit what you would expect of a cup that this size. So again, back then we were doing stratus OCTs, and I don't think there's really not a whole lot of help there. And so the question is she a glaucoma suspect or does she have glaucoma? We really just at that point in time elected to observe her. We'll fast forward here to 2013. And again, she would come in really a couple times a year. She was very reliable, as we'll see in a few minutes. But again, you look at those nerves, they different camera, but I think we'd all agree, they certainly look suspicious. They look glaucomatous, I would even say. Again, looking at this left one, superior and inferior rims look a little thin, but overall, the cup looks really large. And so again, the idea that when you do a disc photograph and you compare them side by side, has there been a change? And again, with different cameras, that becomes harder to do. And again, you can kind of make your own decision if you think there's been a change. Here is our visual field. A right one, again, I think we'd agree is normal, but you look at the left, and really the question is, does this represent a superior arcuate defect, or is this just kind of noise? Is it just, you know, abnormal field, but really not abnormal, and does it represent really true progression? Now, by this point, we were really on to spectral domain OCTs. And so we do a spectral domain OCT. And again, I think you look at both eyes, definitely abnormal. You compare the right and the left eye, and overall, the left eye appears thin. Again, looking at kind of the deviation maps, you look at the, you know, the really how large the cups are and the fact that you've got really thinning in the left eye, more so in the right eye. And again, just looking at the size of the optic nerve, these are big nerves, and the fact that because everything is gray here tells you that the size of her nerve really falls outside of the normative database. And so, yeah, the question is this thinning because this is glaucoma, or is this thinning just because she has a congenitally abnormal nerve and you really can't compare her to a normative database? And I would say at this point in time, that's still really the question that we have yet to determine, right? This is where the pieces of the puzzle don't always match up. She's got very suspicious nerves that, again, at least based on the fundus photo, don't look like there's much of a change. And again, father went blind from glaucoma. And I think we did a couple OCTs. I'll talk more about that in a little bit. We always, when we do an OCT RNFL, we do 3 scans. And main reason being, I want to know, what is that test retest variability? Is this a good scan? Again, remember, the whole idea is we're trying to determine, is there change over time? And so you want to make sure the test retest variability is good. Typically, you want about 3 to 4, even 5 microns from that test retest variability. That doesn't always happen. And the fact is, if you didn't do more than 1 scan, you really wouldn't know what that variability is. And so again, when we look side by side, right? So we've got superior thinning, doesn't really quite match up what we're seeing on the visual field. We do have some inferior thinning. And so the question is, does that represent superior arcuate? And so again, this was 2009. You look at 2013, and by a year later, August of 2014, you can see that that visual field maybe looks worse. And the question is, does that represent progression? And as you can see, at some point, if you're looking objectively, you say, boy, there's just too much going on that, I think this is glaucoma. Let's start her on a prostaglandin. And again, right, father went blind from glaucoma. I think most of us would probably agree that that was maybe the right choice. In these 2-hour talks, I usually do the audience response so we can kind of take some time and kind of get a consensus on what people think. In an hour lecture, it's a little bit harder to do. And so the question, do you think Maria has glaucoma? And again, let me go back, right? We started in 2009. It's 2014, and we finally say, you know what? There's enough things going on. I think, yes, she does. Let's start her on a prostaglandin. And so again, the idea that it's not always cut and dry. Sometimes, again, the more you see them, the more data you collect, and I think you're better able to make decisions. And so do you think she should be treated? Again, if we had more time, we could kind of talk about it. But here's the thing about visual fields, right? So as you follow along, right, here was where we looked at it and we said, she's definitely getting worse. Let's start her on a prostaglandin. But yet here she is a little bit later, 6 months later, and we look at that visual field, and it almost reverts back to really the baseline. So one of my kind of points is that, I learned from Doug Anderson, who's a well-known glaucoma specialist, never make a decision based on one field or one pressure reading, right? And again, not that we did, but here we've got an abnormal test. The question is, should we have repeated the test? And again, we can kind of debate that another time as well. But again, here we've got a couple fields where, they're pretty consistent. And then by 2019, she, the field isn't as good, and it looks like she's a little bit worse. And again, you look at the right eye, almost the same thing, right? She had some pretty good fields in 2014, not quite as good. Well, as I said, Maria is probably the ideal glaucoma suspect patient you could ever want, right? I mean, you look at her beginning in 2014, 2015, even 2016, right? She would come in every 4 months. She was like clockwork. We kind of backed it off in 2017 and 2018, and she was literally the perfect patient. And again, you look at the pressures, never high, never elevated. And so, she's really very interesting, right? We look at her OCTs. Again, not much has changed. Here she is in 2018. We try to do some kind of advanced glaucoma progression analysis. And again, you look inferior. Does that kind of slant down a little bit? Maybe, maybe not. Here she is in 2019. We kind of compare it. So again, the idea, is this just a congenitally abnormal nerve, or does this represent true, well, certainly thinning? Does it represent glaucomatous thinning, right? Here's where it gets interesting to me. So here we are in September of 2020, and we've kind of graduated to 24-2C visual field. So remember that 24-2C checks a few more points within that central 10 degrees, but look at, this field in the left eye. Right. And a couple points, but I think you would agree, right? This is a pretty normal visual field. And And given that visual field, and we'll look at it again, this is kind of looking, she knocked it out of the ballpark in terms of her accuracy. And again, you kind of look, right, as you kind of plot this longitudinally, sometimes a little worse, sometimes a little better. And that's why I really love this visual field index score when you're able to plot it out. The question is, I think it throws everything in question, right? Does she have glaucoma? And I would say I don't think she does have glaucoma. Does she need to be treated? Are you so confident that you would stop it, giving her family history? And that's really the interesting question, right? And I decided I don't think she has glaucoma, but again, let's keep her on latanoprost. It's a pretty benign treatment, and she's pretty reliable. The interesting thing with Maria, right? And remember, this is September 2020. And she was like clockwork. She would come in she was religious. And I noticed probably a year goes by and I'm like, wow, I haven't seen Maria. And then maybe a year and a half goes by, maybe 21, 22. I'm like, let me look and see what's up with her, right? And so I pulled her medical record, and we're an electronic health record to the University of Miami Health System. And I found out that she had passed away. And it was like, holy cow, right? And I believe it may have been from COVID. I don't know that for a fact, but I thought that was the case. And it was like, she was interesting, right? She's fun to talk about. She was great to see because, this mental gymnastics that we go through. Is it glaucoma? Is it not? Does she need to be treated? Et cetera, et cetera. So, but again, what was our role? What was our job, right? Preserve vision for a lifetime. And at least we were able to do that. So I saw there were a few questions that pop up for 10 micron change that you mentioned. What time period would you put that with? Really almost any time period, right? If it was 6 months or a year or even 2 years. Again, not that I would make a change at 10 microns, but if it was more than 10 or 15, certainly 20, to me, that signifies that's progression. I did do ganglion cell complex on her. She was overall just generally thin. And like some of these patients, it just really was not a whole lot of value in her GCC. So that's, I think, a classic example, right? When the pieces of the puzzle don't always fit, right? We gone almost 10 years, over 10 years, scratching our head. Is it glaucoma? Is it not glaucoma? We treated her. We ultimately say, well, I think I still would have treated her. There's enough information, but again, I thought she was one of those interesting ones. Here's another one. Comes in 2020, annual visit, not seeing as well. It's kind of a hazy view. As you can see, he's got a little bit of a cataract. 2025 visual acuity. And I've seen this guy a number of times. His pressure's never been elevated. And again, looking at the nerves, they don't look suspicious, but guess what? If you look at this left eye inferior temporal, it looks like there's a disc hemorrhage. So again, not to belabor disc hemorrhages, but could be from PVD, could be a lot of reasons. But I think in the setting of kind of that proximity to the nerve, I always worry or think about, could this be from pressure? Is the pressure too high? Is this glaucoma? So again, we kind of launch into this. Let's do an OCT. Let's do a visual field. And sure enough, right? We do the OCT and pretty reasonable scans. And I've got highlighted here, the right one completely normal. Again, you look at deviation mats, they kind of both look a little bit kind of thin, but yeah, you look superior temporal. There's an area of nerve fiber layer thinning, and yet you do your ganglion cell complex and you take a look. This is really kind of that squeegee X-Acto knife cookie cutter defect that we see in glaucoma. Not diffusely thin, but this really X-Acto knife that kind of fits. So again, when the pieces don't fit, we've got what looks like maybe superior thinning, but yet we've got on the ganglion cell complex thinning that's inferior. And so I think we would agree suspicious, just looking more carefully at the numbers, and we won't look at that now. And so, treat or observe. And again, disc hemorrhage, haven't got a visual field. I like to get multiple pressures. And so the idea, I'm going to bring him back anyway to do a visual field. I'll get another pressure. So no, I didn't treat him at this point in time. I bring him back to do a visual field. But of course, like many of our patients, right? Just a lousy visual field that doesn't really help you at all. And so you're really relying on OCT measuring pressures. So some thoughts, right? Disc hemorrhage in the left eye, but the OCT shows thinning superior. Doesn't really fit clinically. Visual field shows general progressing, but no really corresponding visual field defect. And as I say, really poor congruity. And so this is what I did. I put him on latanoprost in the left eye. By the way, pressures, right? I think we looked at this already, 11, 13. This becomes important because even though I put him on latanoprost, he comes back and the pressure isn't even lower. It's almost the same. And again, I talk about this is why we do 3 OCT images. This is that test, retest variability. Even though all the scans are pretty good, I mean, you look at the topography of the nerve, especially in this left eye, this second and third scan look pretty good topographically. You look at this first one, it was a little off. I don't know if that really changes the numbers, but again, if you're making a decision and monitoring this patient over time, is the scan getting worse? Point being, and again, this is that first scan, probably not the best scan to use. But again, you look at the numbers, well, certainly some thinning there compared to that baseline. 88 to 78, 85 to 78, that's more than 10. And then my thoughts, right? You put him on latanoprost. Why is the pressure not normal? I think the OCT is basically stable. But again, the question is maybe there hasn't been enough time to determine change. As I look back retrospectively, I thought, well, man, I wish I wouldn't have started him in treatment. And so then the question is, do we keep him on latanoprost? Do we switch? Do we stop? The idea that you put him on it and now you're saying, well, I'm not sure you have glaucoma, or I don't think you need to be on it, or yes, would you even change because you didn't get the IOP lowering effect that you would like to have had? And so you look at some of these visual fields, and again, none of them really get better. They've got these kind of generalized depression. And here he is on this, March of 23 visit where, again, excessively high false positives. And again, we'll kind of look at all these pressures. A couple times, again, we have technicians that don't always do applanation. They did tonopen, which I don't really like. In the setting of glaucoma, we prefer applanation tonometry. Although on this visit, we've got an 8 and a 7, which quite honestly, I'm not sure is real. But again, you look at the ganglion cell complex. Let me kind of go through that really quickly, right? I mean, you look along here, and at least based on the GCC in this left eye, it certainly looks like he is progressing and getting worse. And again, when you look at that 21 to 23, I think especially here, you're starting to see some change. And so, so new, and by the way, yes, my note was in that September 2023, now he has another disc hemorrhage. So he had one in October of 2020, 3 years later, he has another one. And again, my note could consider falling without meds. I think given what we know, that's probably not a true statement. Again, the pressures were pretty low, but again, the idea is latanoprost the right choice. And again, this is somebody that, we just kind of continue to watch and follow. A few words about visual fields, right? Most of us do standard automated perimetry white on right. We know that it's a difficult test to perform. It relies on the patient being able to provide a subjective input. And as we know, not every patient can do it. Many patients have difficulties. And again, there's variability. Even in glaucoma, that variability tends to be more. So glaucoma visual fields tend to show more variability than normal fields. And there tends to be high variability and reductions in sensitivity preceding definitive visual field loss. And so a lot of times these local depressions will kind of come and go. Some days they do better, some days they don't do better. And that's really the challenge, right? So the question that when you're looking at a visual field, is this just kind of short-term variability, or is this just kind of this long-term trend towards worsening? And I think that's the difficulty in if all you have is a visual field to really rely on. Is this real in terms of progression? Or let me bring them back, let me repeat the test. And again, on average, most of us probably only do 2 tests a year, maybe sometimes 1 in somebody that's stable. And the reality is that is probably not enough times to really determine that true progression. And again, that's really for a whole nother topic in terms of stacking visual fields, doing more visual fields to really determine variability. Quick note here, this is from the OAT study. 86% of visual fields that were abnormal when they repeated them went back to being normal. And so again, this idea, never make a decision based on one field or one IOP. If you really are concerned, bring them back and repeat the test, though we know that that's not always easy to do. And so, yes, visual fields are difficult. They can be variable. And we will look at this example of a patient where, just like we showed that other patient, right? This is a superior arcuate that's threatening fixation with the nasal step. And by all accounts, no question, looking at the pattern deviation map, this patient is getting worse, right? And so if you were to ask the question, are they progressing? It really looks that way. But guess what, right? You repeat the test and they kind of go back to really that baseline. So fortunately, that's, I think, one of the great reasons why we have OCTs to really kind of help corroborate some of these questions. Are they progressing? And again, most of these these visual field machines have the glaucoma progression analysis, which really, again, based on probability, also helps you make those decisions. And again, we talked about kind of plotting that deviation map. And again, I think we all lose the forest through the trees sometimes when we're looking at this patient on this visit, trying to make a decision. Are they getting worse? And again, sometimes when you plot that out, it allows you to take a step back and really, I think, get the big picture on, is this patient really getting worse? Or if they are, is it really at a rate of progression that we would really be too concerned about? And so, as we've kind of alluded to, right, the OCT, I think, is that missing piece of the puzzle that really, I think, provides us, that key piece of information in addition to pressure, in addition to looking at an optic nerve in a visual field to really sometimes, answer that question, maybe the definitive question, does this patient have glaucoma or is this patient getting worse? And by now, I think the OCT has been around for about 20 years. Spectral domain came out in about 2005, 2006. And so most OD practices have it. And again, the idea, do we trust the OCT more than we trust the visual field to determine, is there progression? And the fact is, there's great data to show that the OCT can show change before it shows up on a visual field. And keeping in mind, right, whether, again, we've kind of talked mostly with the Cirrus, that's the test or the device that I use. I know there's several other really good ones. And again, not to imply that the Cirrus is any better than any of the others. I think they're all very good. The one thing about glaucoma and OCTs, I think it tends to be more software centric. So whatever device you have, you're used to the software. And again, I think they all do a great job of really highlighting those suspicious nerves, helping us determine, is there progression, is there glaucoma, et cetera. So the point being here, right, there is a large range of normal before all of a sudden we hit that tipping point, that yellow. And so if most patients have an average thickness of about 105 to 110, and you really don't reach that tipping point till about 75 microns, as these OCTs are very sensitive in picking up change within that normal region. And then you look at that between 75 to where you hit the red, that really, moves very quickly from borderline to finally, being red and abnormal. And keep in mind with these OCTs, there is also a floor effect. At some point when you get advanced disease, the OCT really loses some sensitivity in terms of determining, overall thinning. And so again, this is a paper from the University of California in San Diego looking at a group of glaucoma suspects that they followed over time with visual fields and OCTs. And what they concluded was 35% had abnormal OCTs 4 years before they showed up on a visual field, and almost 20% had abnormal fields abnormal OCTs 8 years before they showed up on a visual field. And so they concluded, again, this is Weinrab's group out of the University of California in San Diego, that the OCT is perhaps more sensitive to than visual fields. This is a paper by Joel Schumann. He's one of the co-inventors of the OCT, looking really at the OptiView, and again, essentially showing the same thing, that the OCT picked up change before it showed up on a visual field. And the interesting part of this study was that where the Cirrus loses some sensitivity on the ganglion cell complex, especially with more moderate to advanced cases, on the OptiView, the ganglion cell complex actually remained very sensitive in terms of a measure for determining or documenting progression. So again, the question, right? Does this patient have glaucoma? And again, when the pieces of the puzzle don't always fit, right? Here's an employee of the University of Miami who presented initially in 2017 for glasses. And she would come in every year for her kind of annual exam, really mostly, refractive changes. I didn't see her in 2017, but one of my colleagues, an optometrist who saw her, was concerned enough with her being a glaucoma suspect that at that time did an OCT that we'll show you in a second. And so she would come in, and again, always pressures were fine. Everything looked pretty good. Interesting. She's got this granuloma dissolution in the right eye that I'll show you. But all of a sudden in 2020, she's now got a disc hemorrhage, right? And so the question is, disc hemorrhage, even though pressures has always been good, is that too high for her? And so this is the 2017 visit. And so again, you look at right eye, left eye. I think we all agree they look pretty normal. You can see that little granuloma, little elevated fibrous tissue out in the periphery. The OCT scans look normal. And I don't think they did ganglion cell analysis on that visit. So she came in 18, she came in 19. And then I did not get a OCT on that 2020 visit when she had the disc hemorrhage, I think just because of insurance purposes. But here she was a little bit later. And again, there was still a little bit remnants of a disc hemorrhage, right? And so again, we kind of look at the OCT, and I'll let you kind of compare that in just a second. Here's your ganglion cell complex, which kind of wondered, is that anything we need to worry about? When we compare that 2017 to 2020 OCT, and again, I've kind of highlighted this to make it easy, right? The one thing, you look at, she's got almost 160 microns of RNFL thickness, which, you can have that, which obviously she's got a pretty thick RNFL. And when you look at this, OCT from a little over 3 years later, it's still green. It still looks normal, but yet you see almost a 60 micron really change from that visit. So again, I just told you a change of 10 is significant. Certainly 20 is very significant. And so in the presence of a disc hemorrhage with that amount of change, does she have glaucoma? Does she need to be treated? How concerned really are you? And that was the photo. So this was, let's try to determine when I did. I can't remember if this is really the same time. So this is a little bit later. This is the December visit. And here she is in 2021, where you could still see remnants of this little disc hemorrhage in the right eye. So the idea was OCT and photo on the same visit, not getting it paid for. So I brought her back a couple months again to do a photo and a visual field. And so again, I think you can see the remnants. And so, as is the case, right? Not the best visual field test taker. And so just kind of watch her eye. So I didn't treat her. And it's one of those that I've kind of regretted. It's one of those, if I had to do it over again, type of situations where you're looking, it's quick. Is that change significant? Gosh, pressures of 15. And we do repeat the visual field, and she does a little bit better. And here we are even 9 months after that. This is September 21. And I think you would look at this visual field and say, well, it's completely normal. So even though we've lost significant RNFL, if you believe that to be true, in the presence of a disc hemorrhage, yet she continues to have a normal visual field. This is the left eye, this is the right eye. And so here she is in March, still's got excellent pressures. And now look at that ganglion cell complex, right? And I'm going to show you serially what that looks like. And so let's kind of compare again, December 20 to March of 2022. Well, if you're looking at the right eye, I would say it really is stable, at least the RNFL. Interestingly, if we're looking in the left eye, the question is that represent, well, progression? And by the way, she's a dry eye sufferer as well. And this was my note. And so I kind of followed her. And guess what? Indeed, she gets worse. Pressure of 14. And I haven't answered the questions. We will, and maybe I'll finish after this one so we can answer some questions. Do I do, would I work it up? Does she get an MRI? No, unless there's pallor. I mean, I don't think this is anything other than normal or low tension glaucoma. And so again, I think serially we're going to see that she does get a little bit worse. Comparatively speaking, I think you're going to be able to see that on her ganglion cell complex, again, serially. And so here's somebody where it took a little bit. By the way, she also has a horseshoe tear on this visit, so I sent her to my retinal specialist who's just down the hall, and she did come back. So again, you're seeing this general trend towards progression, in the presence really of never having high or elevated intraocular pressures.